Good morning all. Today we'll see how to write the answer for aggressive periodontitis. This question is normally asked in the long question. So question might be define aggressive periodontitis, give clinical feature, radiographic finding and treatment plan. Just because it's a long question, we'll be writing the content. We'll write the answer, aggressive periodontitis and the content. We'll be writing introduction, definition, history, classification, clinical feature, microbiology, radiographic feature, etiology and then treatment plan. Introduction, it should be very easy one to remember. So keep the introduction very short and easy. Periodontitis is a multifactorial complex disease and it is caused by the interaction of microorganism with the bacteria. Or you can write periodontitis is a multifactorial complex disease, an upregulated or maladapted immunoinflammatory response to bacterial plaque which predisposes patient to periodontal breakdown. Coming on to the definition. Important keyword in the definition are it is a very rare disease, not normally seen, and second keyword is it is severe. It is rare, severe, it is rapidly progressive form of periodontitis, often seen in the early ages of clinical manifestation. It is normally seen in the young patients. So it is first keyword is it is rare, severe, rapidly progressive form of periodontitis, often characterized by earlier age of clinical manifestation and a distinct tendency for cases to run in a family, aggregate in a family. That means the patient might be having some genetic tendencies. Coming on to the history. In 1923, Gottlieb assumed that it is a disease associated with the alveolar bone and hence the disease was named as diffuse atrophy of alveolar bone. Later on, it was named as deep cementopathia and followed by periodontitis marginalis progressiva. And in the year 1967, it was named juvenile periodontitis. In 1999, it was named aggressive periodontitis. Clinical feature. Important clinical feature is onset around puberty. It is very important to learn that it start around the age of puberty and mostly in localized aggressive periodontitis, central incisors and molars are affected, and the disease will progress very rapidly and the distolabial migration of incisors will be seen, followed by the diastema formation. And the disease, although it is spreading so severely and rapidly, minimum amount of plaque will be there. So onset, important keyword is onset around puberty. Since the disease is spreading very fast, distolabial migration of maxillary incisor, minimum plaque and inflammation, mobility of maxillary and mandibular incisors, sensitivity of denuded root surface, deep, dull, radiating pain during mastication, or might be periodontal abscess. Radiographic feature. Vertical bone loss around first molar and incisors, arc-shaped bone loss of alveolar bone extending from the distal surface. This is very important viva point of view also. From the distal surface of second premolar to the mesial surface of second molar. Arc-shaped bone loss or vertical bone loss, and bone defect are wider as compared to the chronic periodontitis, and moreover mirror image formation will be seen. Students normally get confused with the mirror image. What is mirror image? Mirror image means the bone loss pattern that is there on the right hand side of the jaw is very much similar to the bone loss pattern that is seen on the right hand side of the jaw, as if the arc shaped bone loss is looking into the mirror. That means the arc shaped bone loss is there on both the side of the jaw. In 1999, it was named as aggressive periodontitis, and in the same year, Lang proposed that there are certain common features that is mandatory to be there to be called as aggressive periodontitis. And these three important features are: patient should be otherwise clinically healthy. If we see a patient at very young age and very mobility of teeth and bone loss, severe bone loss with very less amount of plaque accumulation, the first and most important question that we should ask with the patient is whether patient is suffering from diabetes mellitus or not, or any other systemic condition. If patient says yes, he or she is suffering from some medical disease, then the patient will not be called as aggressive periodontitis. So most important thing is that patient should be otherwise clinically healthy. Rapid attachment loss and bone loss will be there. We'll see what exactly is the reason why so much of attachment loss and bone loss is seen in such an early age with minimum or no plaque. And then familial aggregation. There might be some genetic disease associated which lead to so much of bone loss. So these features are mandatory to be there in aggressive periodontitis. Patient should be otherwise clinically healthy. Rapid attachment and bone loss, familial aggregation of the cases. Secondary features. According to Lang in 1999, secondary feature, it is not mandatory that all the feature will be present to be called as aggressive periodontitis. So few of the feature may be present or may not be present. So first feature is amount of microbial deposit are inconsistent with the severity of periodontal destruction. That means although patient might be having very less plaque, but destruction will be very severe. And we'll see later on why the condition is like that, because of very less, although there is very less plaque, so much of destruction is there. So first reason is there might be elevated proportion of aggregatibacter actinomycetam comitans. The bacteria might be having few virulence factor. Because of that, the disease is so severe, so aggressive. Or in some population, there might be presence of Porphyromonas gingivalis. Second is phagocytic abnormalities. The patient might be having some phagocytic abnormalities. Whenever some bacterial infection is there, in order to get rid of this bacterial infection or to control the infection, our immune system get activated. The neutrophil, it tries to engulf the bacteria, tries to kill the bacteria, and once the bacteria is killed, it will try to phagocytize the bacteria in order to remove the remnant of the bacteria from the site. And if the bacteria is not cleared from the site, if the bacteria is not cleared from the site, then the remnant of bacteria will be there, and this is called as lipopolysaccharide, and this will cause the continuous inflammation. So if the patient's phagocytic abnormalities is there, the bacteria they are not getting cleared from the site, then continuous inflammation will be there, and because of that continuous inflammation, the teeth loss and mobility will be there in very young age. Hyper responsive macrophage. If the macrophage is hyper responsive and with relation to very small stimuli, it is getting hyperactive and it secreted large amount of prostaglandin E2 or interleukin, then this prostaglandin once activated, it will lead to the activation of multinucleated osteoclast, and this multinucleated osteoclast will lead to resorption of bone, similar with interleukin 1 beta. So if macrophage is producing excess amount of prostaglandin, then the disease will be very severe. Progression of attachment loss and bone loss may be self-arresting. The disease might be self-arresting. We'll see later on why the disease is self-arresting. Classification in 1999. It is classified as localized aggressive and generalized aggressive periodontitis. In generalized aggressive periodontitis, at least 3 permanent teeth other than first molar and incisor are also involved. Usually affecting person under 30 years of age, but patient might be older. Poor serum antibody response to infecting agent. That means the serum response to the antibody, the serum response or our antibody response or immune response to the foreign body is not that robust. So that means the bacteria is there and the immune response is not that good enough. It is poor. That means the immune cell, they are not capable enough to get rid of the bacteria. Then the disease will progress. So what will happen? A bacteria is introduced in the body. We'll see why the bacteria is so aggressive, because of presence of various virulence factor. And if body cannot control the bacteria, our immune cell cannot control the bacteria, then the disease will progress at a very fast rate. Pronounced episodic nature of the destruction. Etiology and pathogenesis. So then we will be writing the etiology and pathogenesis of the disease. Bacterial etiology, genetic aspect and an environmental aspect. Bacterial etiology. The microbiota associated with the localized aggressive periodontitis is predominantly composed of gram-negative anaerobic rod. 90% of that are aggregatibacter, actinomycetam, cometan. Other microorganisms associated are P. gingivalis, Echinacea corydon, Campylobacter rectus, and Fusobacterium nucleatum. So we are repeatedly saying aggregatibacter, actinomycetam, cometan is associated with the disease. So uh, before we proceed with the answer, we should know what exactly this bacteria look like. What are the features of this bacteria? So we will be writing it is a small, short, straight or curved, non-motile, gram-negative rod. Gram-negative and anaerobic rod. And the colony characteristic is white, translucent, smooth colony with star-shaped internal appearance. This is very important. It has star-shaped or cucumber-shaped internal appearance of this colony. Then the virulence factor. Why this bacteria is causing so much of disease? First is leukotoxin. The bacteria that is there, it is killing the leukocytes, that is reaching at the site of inflammation. Whenever a bacteria is introduced, leukocyte will be there to get rid of bacteria. But this bacteria is producing leukotoxin in order to protect itself. And if excess of leukotoxin is being secreted, then the destruction of leukocyte will be there. That means the number of bacteria will increase and the leukocyte will not be able to control the aggregatibacter, and hence the disease will be severe. Another important virulence factor of aggregatibacter is endotoxin. It secretes various inflammatory mediators such as prostaglandin and interleukins, so that inflammation continues, inflammation goes on. And if inflammation goes on, just because it's a proteolytic bacteria, if inflammation will be there, breakdown product of the tissues will be there, and the bacteria will flourish. So it causes continuous inflammation, and it do not want the leukocyte to be there. Moreover, it do not want the growth of other bacteria also. So bacteriocin, it may inhibit the growth of other beneficial species. So this bacteria, what it is doing, it is causing continuous inflammation, and it is preventing leukocyte and other bacteria from proliferating and controlling the inflammation. It is secreting various immunosuppressive factor, so that inflammation, so that the neutrophil function will be hampered. Collagenase, it is causing degradation of collagen, so that if the breakdown product of collagen will be there, the bacteria will flourish. Then chemotactic inhibiting factor, it do not want neutrophil to reach at the site of inflammation, because once the neutrophil will reach the site of inflammation, a war will be there between bacteria and the neutrophil, and the bacteria might get killed with the neutrophil. So it is first secreting chemotactic inhibiting factor also, so that neutrophil might not arrive at the site of inflammation. And other thing is causing, if just in case if neutrophil will arrive, it is causing leukotoxin. So if the neutrophil will arise, it will be killed. So because of this, the disease is very severe. It is very important to learn all the virulence factor of aggregatibacter, actinomycetam, cometan. Next is genetic. It is autosomal dominant both in African and American. Caucasians differ in different ethnic group. It has been shown that the structural and functional difference in FCGR 2A are due to genetic polymorphism. Basically, FC portion of IgG, the immunoglobulin IgG that is there, it helps in phagocytosis of the bacteria. And if immunoglobulin is defective, the bacteria will not be phagocytized. So if patient is having some genetic abnormalities related to immunoglobulin production, then the disease will be very severe. The disease will be in the form of aggressive periodontitis or some phagocytic defect. If patient is having some phagocytic defect, then also the disease will be very severe. Environmental factor, smoking. In a large study group, cigarette smoking was shown to be a risk factor for patients with generalized form of aggressive periodontitis. Diagnosis, how we can diagnose? Clinical diagnosis by medical and dental history, clinical examination of periodontia, radiographic examination, and microbiological examination. But purely on the basis of microbiological examination, we cannot say the patient is suffering from aggressive periodontitis, because there are different serotype of bacteria, of aggregative bacteria associated with the disease. So the diagnosis is made on the correlation of clinical, radiographic, as well as on the basis of microbiological. Prognosis. When diagnosed early and appropriate treatment, excellent prognosis. Advanced disease prognosis may still be good if lesion treated with scaling and root planning, systemic antibiotic, and regenerative treatment is done. Poor prognosis, impaired host response, does not respond well to conventional periodontal therapy treatment. Improve oral hygiene, scaling and root planning, antibiotic therapy, followed by the periodontal surgery. In non-surgical part, we will be writing patient education, scaling root planning, oral hygiene improvement, regular recall maintenance. In surgical, we will be writing resective surgery to eliminate pocket if one wall defect is there. Limitation of resective surgery is that it may further compromise teeth that are mobile because of extensive loss of periodontal support. So go forward with the regenerative surgery if three wall defect is there. But if one wall defect is there, then we cannot do anything. We will go with resective surgery. If three wall defect, we'll go with regenerative bone grafting, GTR, done in vertical defect. In antimicrobial treatment, use of antibiotic has been suggested as a complement to mechanical debridement in these cases. The choice of antibiotic should be guided by the information about the nature of involved pathogenic microorganism. Based on the culture, if predominantly gram positive, then augmentin is prescribed. If predominantly gram negative, clindamycin is prescribed. If predominantly anaerobic, then metronidazole or a combination of metronidazole or amoxicillin. Thank you so much.